class 3, then it is classified as intermediate risk. For those high risk, patient with arrhythmias, unstable angina, recent MI, NYHA class 4, all these are high risk. The the um, the purpose we classify into low intermediate risk is actually we want to see how we are going to manage the patient. So if low risk category, it can be managed in primary care center. We can give treatment, and then we can monitor the patient in primary care. But intermediate and high risk, we need to assess their cardiac function first before we provide treatment. Specialized evaluation recommended, like an exercise stress test, and high risk as well. Okay, this is the important algorithm. So patient with confirmed ED, then you need to risk stratify the cardiac risk according to the just now the one, the Princeton consensus. And we need to risk stratify to low risk, intermediate risk, as well as high risk. Okay, so those with intermediate risk or low risk, you can actually the intermediate risk have to do a stress test but low risk elective risk assessment also you can consider for stress test if you think the patient need a stress test, and you look at the result the result stress test is positive, then you need to refer for further cardiac assessment. Okay, if low risk then advise the patient and then offer the patient for PDE5 inhibitor. So before you prescribe the PDE5 inhibitor, you need to see whether the patient had been prescribed with nitrite, GTN, all those things. If patient is on nitrite, then it's contraindicated for you to start PDE5. Okay, besides cardiovascular assessment in this ED, we need to assess also the psychosocial assessment, psychosocial assessment of the patient. Sexuality is a central part of the human life, and it encompassing the feelings that are experienced and expressed in language, thoughts, belief, attitude, values, behavior, and practice, and relationship of the patient. And firstly, you must conduct the interview, the consultation in a comfortable surrounding and ensure privacy. Be empathetic, non-judgmental, and understanding. Use language in which a patient is comfortable with. Use neutral terms, and use anatomical drawings to help patient to understand more. Okay, area of assessment for psychosexual, you need to assess the PHQ-9 and GAD-7 if the patient has stress, when you detect anxiety or depression. Then you need to assess the relationship history, any issues with the partners, dynamics, duration, and partner history, communication, as well as health of the partners. Partner sexual functioning, like example, the female sexual dysfunction. Then you may want to assess patient's life stressor and coping abilities. Cognitive factors like dysfunctional thinking style, expectation of sexuality and sexual performance, and treatment preference of the patient. Then you also may want to assess the sexual related factors. Education, how you can assess the patient, how the patient learn about these sexual activities, childhood and adolescent sexual learning activities. Trauma, the patient had a sexual assault before, there's trauma. Okay, experience like masturbation, how many times they masturbate. Okay, pornographic usage, interpersonal sexual activities, breadth and flexibility of sexual script with all partners. Okay, so this one also need to ask the patient what is their sexual orientation, what they are practicing, what the patient and the partner is practicing. Okay, and as well as cultural and religious aspects, gender dysphoria, sexual orientation. Then you also assess the comorbid sexual dysfunction, like the premature ejaculation. So after you assess all those things, then you need to you can offer treatment. These 5 modalities can be combined. The lifestyle modification, pharmacological, mechanical, surgical, and psychological. So the first thing is lifestyle modification. You may want to ask the patient to increase physical activity. Aerobic exercise of moderate to vigorous intensity more than 3 times per week. more than 30 minutes, improve the IIEF score. Weight loss, for patients who are obese, you can ask the patient to take a low-calorie diet, fast physical activity stuff will improve erectile function. Balanced diet, just now, what are the risk factors is actually the not healthy diet. If you may want to consult, you may want to ask the patient to eat a healthy diet to improve the ED. Okay, pelvic floor muscle training, you can refer this to our physiotherapists. They can teach the patient to do a pelvic floor muscle training. Then medication, the first line is actually the PDE5 inhibitor. It causes a smooth muscle relaxation and subsequent increase in arterial blood flow to the penis. But usage of this PDE5 is required environmental and psychological cues for sufficient sexual arousal and stimulation for erection, which means PDE5 is actually is not the initiator of erection. So you still need to have a visual, auditory, or tactile stimuli for erection, even though you use PDE5. So it is usage of PDE5 is contraindicated in those who receive nitric oxide and organic nitrates such as GTN. Okay, this is the mechanism of PDE5. So PDE5 inhibitor is actually block the PDE5 enzyme, thus increasing the CGMP. The increase of CGMP will eventually lead to relaxation of vascular smooth muscle. So if the patient also taking nitrite GTN, it will subsequently increase this CGMP further, causing more muscle relaxation and then subsequently hypotension that we don't want. Okay. So PDE5 inhibitor, there are four PDE5 inhibitor in Malaysia. The first one is sildenafil or Viagra, 25 to 100 milligram. It is taken 30 minutes to 1 hour prior to SI. Then the next one is tadalafil, 10 milligram taken 30 minutes. Avanafil, 100 milligram taken 15 minutes. And vardenafil, 10 milligram taken 30 minutes prior to SI. So for the comparison, each of the PDE5 is actually very fast acting. 30 minutes of onset, some even 15. Most of them are 30 minutes. And it lasts maybe 4 hours. Only tadalafil, it will last 17 hours. All this PDE5 is actually on demand when 1 hour, when the patient wants SI, then only you take. Okay. Except for the tadalafil. Tadalafil you can give daily dosing, but tadalafil may be used in PPH patient. So if PPH patient with ED, then maybe we can refer to urologist to start this tadalafil. Okay. Effect on food. Then sildenafil, delay by fatty food. So patient may need to take on empty stomach. Okay, those with ESRF may use lower dosage. Okay, side effect of PDE5 inhibitor. The common one is headache, flushing, dyspepsia, nasal congestion, myalgia, visual abnormalities, and back pain. These are the common side effects. Or the rare one is prepism, the painful erection is a rare side effect of PDE5. So patients who are on PDE5, if the patient complain of sudden vision loss, you may want to ask the patient to stop PDE5 immediately because we are worried about this non-arthritic anterior ischemic optic neuropathy. Okay. So the next intervention is actually intracavernosal injection. You can refer for urologist for the ICI aprostadil, intraurethral aprostadil. This patient, the downside is patient may need to learn to administer all these if you want to refer for intracavernosal injection. So the adverse effect may be local pain, there are hypotension, penile fibrosis, prepism are rare, urethral bleeding, and UTI. These are the adverse effects for this intracavernosal injection. So the next other treatment modalities include vacuum erection device. surgical intervention like penile revascularization surgery or penile prosthesis. These are the penile prosthesis you inserted inside your penis, and it is when you want to have SI, maybe you need to inflate. Okay, the psychological intervention is actually very important for ED. So you may want to combine pharmacological as well as psychological. You may want to refer to psychologists for this intervention, like the cognitive behavioral therapy, interpersonal therapy, mindfulness therapy, sex therapy, marital therapy, as well as group therapy and counseling. You can refer to our psychologist to for this intervention. Psychological intervention, when combined with pharmacological treatment, is more effective on ED outcomes than individual treatments alone. A collaborative approach, psychological and pharmacological, offers patients the best chance to recovery. Psychological intervention, when properly applied, significantly enhance the outcome. Multidisciplinary collaboration is the key. Okay, follow up. Short term, when you start the patient on oral medication, you may want to schedule 2 weeks to maybe 2 months to just to assess the response of the medication. If long term, once the treatment is established, then you may want to monitor him and adjust the treatment as needed. Okay, indication for referral, when you want to refer to a urologist, when the patient had treatment failure or complex cases, unknown or unclear causes. That means you cannot find the cause for this ED. It's not psychogenic, it's not, then you may want to refer to our urologist for advanced workup. Fail oral medication, or maybe the patient need injections, then the other device or surgery, you may want to refer to them. Psychological factors. Significant psychological contribution to ED. When you detect some severe psychological factors, then you may want to refer to our psychiatrist for intervention. So important thing, the take-home message is for this ED, the important thing is comprehensive medical, psychosocial, and sexual history must be taken in every patient. Then you must do the IIEF 5. The validated questionnaire with the EHS, the erectile hardness score, everyone should be performed on every patient. Okay, a focused physical examination in the initial assessment of men with ED should be done to identify underlying medical condition and comorbids. Routine laboratory tests should be performed to identify modifiable risk factors. Specific diagnostic tests may be performed when it is indicated only. Patient with ED should have cardiac risk assessment and vice versa. So again, ED, when patient present with ED, we need to assess the cardiac function. So this is the important algorithm. Okay, patient with symptoms of ED, so you need to take a history, everything, just what I said just now. And if you made the diagnosis of ED, you may want to classify the type of ED. Is it organic or psychogenic? Okay, and then after that, you need to do IIEF 5 scoring for this organic ED. So mild to moderate, 8 to 21, if the scoring, then you can institute the lifestyle modification and pass pharmacotherapy. If there's no improvement, then you need to refer to urologist for other further assessment or other intervention. If the score, IIEF score, is already very severe, 5 to 7, then you immediately refer to urologist. You may want to institute lifestyle modification, pharmacotherapy, as well as mechanical device and surgical intervention. So if psychogenic ED, then you may want to lifestyle modification. You may want to ask the patient to lifestyle modification and pharmacotherapy. Refer to mental health professional if indicated. Okay, then the other one is this algorithm also is important. So if patient will confirm ED, you need to risk stratify the cardiac risk stratification, low risk, intermediate risk, and high risk. Then you may want to consider the stress test for those intermediate risk, and low risk. So after the stress test, then you see whether there is cardiac problem or there is no cardiac problem because it will affect on the management of the patient lah. Okay, next is premature ejaculation. So PE, ejaculatory disorder are a heterogeneous group of disorder that include premature delay and retrograde ejaculation and anorgasmia. Okay, so today we will focus on premature only lah. The definition of premature ejaculation is ejaculation that always or nearly always occurs prior to or within 1 minute of vaginal penetration. This is for first episode. And then, or it can occur 3 minutes of vaginal penetration if the patient had new onset lah. And the inability to delay ejaculation on all or nearly all vaginal penetration and causes distress. So all these three must be present to say there is PE. So either 1 minute or 3 minutes, then the inability to delay ejaculation and it causes distress to the patient. So this is PE, the definition. So there are types of few types of PE, premature ejaculation, according to International Society of Sexual Medicine. So you can classify to primary, less than 1 minute in all sexual encounter. That means this patient first SI also ejaculate less than 1 minute. Then this is PE lah. Okay, if acquired, that means previously the patient had previous normal ejaculation time, but now it ejaculates faster. So it's less than 3 minutes is a new onset. Then it's also considered as PE. Variable. The next one is variable. It's variable timing. Sometimes PE occurs, sometimes no, sometimes normal timing. This is actually a normal variance of sexual performance. And the last one is subjective. Subjective, self-perceived of rapid ejaculation. But patient does not have this premature ejaculation. So this is most likely is psychogenic. So the risk factor of PE, first is again the low serum testosterone level. Then patient with loop symptoms, the more severe, the higher risk of PE. And again, older age, those with higher age, that mean we have a higher risk of PE. Medication, alpha blockers, 5-alpha reductase inhibitors, SSRI, have been associated with ejaculatory disorder. Surgery for BPH commonly result in retrograde ejaculation. Those patients will have DM at high risk of retrograde ejaculation as well. So again, when we approach a patient with ED, when PE, when we approach a patient with PE, we must take a comprehensive history taking, similar to ED as well. All those history taking. First, you establish the presenting complaint. Then you establish the intravaginal ejaculatory latency time. That means how long does the patient ejaculate after penetration? That's the important one. Because we want to classify whether it's primary or acquired. Okay. Then perceived degree of ejaculatory control. How he can control. He can control or cannot control at all. So degree of the patient or partner distress. How distressed is the patient? How distressed is the partner? Then the onset and duration of the PE Then as well as the psychosocial history. Inquire also about the partners relationship, social, cultural issues related to PE is mandatory. Self-estimation by the partner as well as the patient. So you ask the patient how long does he ejaculate? What time is it less than 3 minutes or less than 1 minute? Then you ask also as well the partner how fast does the partner ejaculate. Then you can come to a conclusion of determining what is the actual time of the intravaginal ejaculatory latency time. So these are the recommended questions. What is the time between penetration and ejaculation? Can you delay the ejaculation? Do you feel bothered or annoyed? This is for diagnosis. Then you need to, these are optional questions. you need to differentiate the lifelong and also as well as the acquired premature ejaculation, as well as you need to assess the erectile function, like just now the IEF5 as well as the EHS lah. Assess the relationship impact. Okay, how was the relationship between the two partners? Okay, previous treatment is important. Do you have a previous PE and then you have treatment? Then the impact on quality of life. For this PE, we actually did not have a well-validated question A, like the IIEF 5 is well-validated. For this, we can use the premature ejaculation diagnostic tool, PEDT. So this is for premature ejaculation. There are 9 questions. It is also patient administered. That means patient scoring of the how's the PE. How difficult is it for you to delay the ejaculation? Do you ejaculate before you want to? Do you ejaculate with very little stimulation? Do you feel frustrated? Do you feel your sexual confidence is affected? Do you feel you have control over the timing of your ejaculation? Does your time to ejaculate leave you feeling disappointed? How concerned are you that the time of ejaculation leaves your partner sexually unfulfilled? Does your time to ejaculation leave you or feeling dissatisfied with your sexual life? There's no actual cutoff point to like the IEF5. You have actual cutoff point like less than 8 is very severe. For this PEDT, is actually there's no cutoff point. So you may want to reassess again, then you see any improvement in the PEDT questionnaire. So for the physical examination, similar to the ED, we need to assess the cardiovascular assessment. The most important thing is BP, BMI, waist circumference. Then you do a focused genitourinary, including the prostate, endocrine examination, vascular as well as neurology. Physical examination may reveal penile abnormalities like the Peyronie's disease. So the lab investigation, similar also to the ED, you need to, it is not, there's no routine. It is tailored to patient signs and symptoms as well as risk factor. But the most important thing is, again, the CVD, the FLP, the FBS, the HbA1c, and additional lab testing like the early morning testosterone, PSA, prolactin, and LH is depending on the patient. Okay. Management of PE, psychotherapy is you can help psychotherapy like empowering the patient, improving the confidence in patient's sexual performance, and reducing performance anxiety. So you can refer to our counselor or our psychologist for this psychotherapy. Then behavioral therapy. Behavioral therapy is there's low evidence. It is not a convincing evidence to help with PE, but it's a low evidence. So the stops technique, you can actually teach the patient the stop technique. You stimulate the penis until just prior to orgasm and ask the patient to stop until the urge to ejaculate goes away. It's acting like a desensitization. Okay. And then the squeeze technique, stimulate the penis until just before the ejaculation, then squeeze the glans penis until the urge subsides. Okay, the next one is you can refer to our physiotherapist for this pelvic floor exercise to improve PE. But these are all low evidence. Okay, for the pharmacological treatment is actually SSRI. SSRI has been shown to improve premature ejaculation, but it is not in our formulary. It is actually used as off-label. Okay, the most effective SSRI is actually paroxetine. It can actually improve the IE, the intravaginal ejaculation latency time by 8-fold. So it actually delay this if you prescribe the patient with paroxetine. Okay, then the other thing is you can offer the patient for topical therapy like the lidocaine, like the lignocaine gel lah. So you apply before you have this sexual penetration, then it may desensitize the penis and improve the latency timing. Okay, take home message for this PE. This is the important table. So there are four, remember there are four types of PE. So if less than 1 minute or less than 3 minutes, this is primary or secondary. Okay, and then this variable is actually the normal variance of the performance, and then it's subjective. That means the patient felt that is very fast, but it's actually there's no it's mostly psychological okay, and there are different management for this treatment. Okay, you can read later. Okay, this is the algorithm of management of for PE. So initially, you need to get the history, detailed history establish the presenting complaint, then establish the intravaginal ejaculatory latency time, then the perceived degree of ejaculatory control, then the degree of distress, the onset, the psychosocial history, the medical history, and the physical examination. If it does not point to any primary or secondary PE, so it most likely is PE-like ejaculatory dysfunction or not natural variable. Okay, treatment is reassurance, education. Maybe patient may need some psychotherapy as well as behavioral therapy But if this detailed history and examination, you found that there is true PE premature ejaculation, then the first thing is you need to establish whether ED is it caused by ED or as well, okay, or other sexual dysfunction. If yes, then you need to manage the ED as well as other sexual dysfunction okay, before the PE will improve. Okay, if no, then you need to divide whether this is a lifelong PE or whether this is acquired PE Okay, if acquired PE, then the treatment will be different. Then behavioral, we have psychotherapy, we have pharmacotherapy, and as well as combination therapy Okay, for the lifelong PE, then we need to start with pharmacotherapy then the second line will be behavioral, then as well as combination treatment. It also depends on patient preference whether patient wanted pharmacotherapy or behavioral therapy So after that we need to monitor the patient whether it is improving or not, and we need to schedule a follow-up for his PE. So this is my last slide. So ED and PE is an important element in men's health. Should be proactively screen those at risk. Treatment for sexual dysfunction can be initiated and monitored at primary care level. Timely referral when necessary Okay, this is the take-home message. Okay, that's all from me. These are my references
Okay, thank you, Dr. Ken, for the CME. So, are there any questions or point of discussion that we would like to ask? So I think everyone is
no question.
Yeah.
No question.
Dr. Lim.
Oh, I'm Dr. Lim, FMS from TK Pride. So everyone is clear. If clear, can we have one person to answer what you need to educate patient when you want to start patient on PDE5 inhibitor? Anyone can answer?
Yeah, anyone?
As usual, no one will volunteer. So can we choose somebody?
Yeah.
So in my screen, the next person is Jamalia. So Jamalia, macam mana educate patient? Let's say you assess patient and patient's got ED, right? Then you assess the cardiovascular assessment. Okay, they are low risk. Okay, then you put counsel on PDE5 inhibitor Of course, including you punya non-pharmacol lah, but the first line of treatment is still your PD-1 inhibitor kan. So you kata, okay, nanti I prescribe, you pergi beli dekat pharmacy. That's the reason they want you to prescribe, so they educate patient. So how you educate patient? Ada Kak Jamalia?
Hello, hi.
Yeah.
Basically, I would like to address regarding the side effect of the phosphodiesterase inhibitor. A common one like headache, maybe have dyspepsia, nasal congestion, the back pain. So the common side effect lah regarding that medication.
Okay. Apa lagi?
Then
The most common yang selalu patient complain dekat saya is flushing and giddy lah. Sebab dia vasodilate kan. So patient selalu flushing kan. So what else? Okay,
And
tepat.
the emergency one like that the Dr. Ong mentioned regarding the eye symptoms such as blurring of vision and loss of vision.
Yep.
Okay.
Yep.
Good. Apa lagi? Okay, pass dekat kawan you. Kamaru, the next one. Apa lagi educate patient? Okay, tak ada. Ada pun Syamini? What other thing you want to educate patient? Syamini? Ini mana Syamini? Tak ada. I thought no question. Tapi sudah tak ada dekat sini, that's why no question. How about Wong? Wong Kok Ho kan? Wong? Semua sudah tak ada. That's why everyone kena buka itu video baru nampak muka kan. Wong? Tak ada juga.
Wong not around.
Oh, not around.
Yeah, who is
Then
around?
Lin UKM? So, tak ada juga.
Wong got patient.
Oh, then the rest, who else got? Sophia. I think in the future, probably everyone kena on the video lah, baru tahu ada ke tidak.
Yeah.
Kan, waktu tanya pun tak ada jawab. Yang lain siapa yang boleh jawab? So you can't educate on side effect. Apa lagi?
Agree, Dr. Lim. For the next session, need to on the video.
Sorry lah, I dekat rumah sebab hari ni sebenarnya I on MC. So saya tak buka video lah. Tapi I was around. I'm around. So next. Muhammad Fatir. Okay, siapa yang ada? Boleh kak jawab? A bit shocking, right? Semua pun tak on video. Can everyone on the video?
Dr. Lim. Probably
Yeah.
after we maybe after we have already
prescribe the medication to the patient with a clear indication why he's taking it, then we should tell the patient how to take it lah. Patient should take it like 30 minutes before the planned sexual activity, and then the medication shouldn't be taken with heavy meals or oily food as well, because it can actually interrupt with the absorption of the medication. So, and then it shouldn't be taken more than once. So we have to educate the patient how to take it so that they can achieve the maximal effect from the medication.
Okay, usually the treatment failure is we don't educate patient to take properly lah. Kan, kalau sildenafil, sometimes we tell patient to take 1 hour, then if possible, without food, especially oily food yang will reduce the absorption. Then you need a stimulation. The anti-infective inhibitor is not a magic drug lah, bukan makan terus naik dah. You still need a stimulation. Okay, then we tell patient lah, we start you this dose, it doesn't mean you respond straight away. You might need a higher dose. Usually you don't start you start low dose and you go higher in the, kalau tak respond you go higher. Kan? But very important lah, please tell patient if you got any problem, you go to any medical practitioner, you must tell them that you're on this medicine. Okay, then only they know that you are on this PTF inhibitor. They don't give you all this nitrate lah. Or they are very cautious when they start anti-hypertension, especially your alpha blocker. Okay, so must inform patient. They must tell the practitioner that they are on this ubat. Okay.
Okay.
I think banyak yang sudah tak ada lah. Nak tanya soalan pun tak boleh tanya. So next time should open the video lah.
Okay.
Itu Malini pun is a trainee. Actually, I want our KK and MO to jawab. Okay.
Okay, thank you, Dr. Lim. Okay, so a lot left. So, okay, is there any more questions?
I'm thinking want to teach them to start treatment so that they know to refer every ED cases to us. Mana tahu semua sudah pada.
Yeah, no, now a lot of left already. Okay. So since there's no any question, so shall we end our session today? Thanks all for the joining CME, and please fill in the attendance with the link provided in the chat box.
Thank you, Dr. Lau.
Yeah. Thank you, Dr. Ken. Thank you, Dr. Lim. Thanks everyone for joining us, and hope to see you all at on the next sessions with video.
Thank you.
Okay, thank you.
Thanks, everyone. Bye.
Thanks. Bye.